Hello there. Once again, we are live. I'm at my home office. So let's grab an MRI scan from the queue and read it live. So this is it. You guys see all that I can see. And let's see if we can make some diagnosis today. This is a 68-year-old female patient. She says she has pain in her left shoulder. And I do agree with her. For sure she does. Because let's see if I am anonymizing this. Yes, I am. There is no private information in these images because it's illegal to do so, and we are not here to commit crimes, just to report MRI scans and maybe some CT scans. So I'm going to, this is the shoulder. This is a very low quality exam. This is probably a lower field scanner. It's really shaky, filled up with noise, and it gets worse because surely the patient has a lot of pain, is in a lot of pain, and could stand still during this attempt of an exam. But I guess we can manage to say stuff about this exam for sure. There is arthrosis, there is synovitis, also a bunch of signs of pleural effusions and whatnot. I'm just going to take the chat window, pop it out, and see if we can. Yep, stream is healthy. The chat is here, so I'm just going to stick this chat window somewhere here where I can see if any of you guys say anything, just to be sure not to miss any comments on the spot. There you can see, but I can't. It's all right. So I'm going to boost this with zoom, just some zoom, and this is a coronal PD, proton density image with fat saturation. We usually don't do T2 on bones and joints unless in some particular cases where we want to see the T2 appearance of a lesion for some reason, but we usually do just PD, which is fine most of the time, but it needs to be done with fat saturation. If it doesn't, it makes no sense. So I can readily see here there is synovitis and arthrosis of the acromioclavicular joint. I can also say there is joint space narrowing right here and a bunch of small osteophytes. This is arthrosis of the humeral glenohumeral joint. Also, there is a bunch of liquid or liquid-like structures right here. So there is joint effusion, a moderate joint effusion on this shoulder joint, and it distends, of course, the subacromial bursa or the subacromial joint recess. This is quite common. They intercommunicate, so if one distends with liquid, the other also goes in the same path. So this could be called also a bursitis. It could be called a subacromial bursitis, and we have a proper bursitis right here. It is a subacromial subdeltoid bursitis right here, and we know the motive for such bursitis. It's a rupture of a tendon. Which tendon is this? Let's see. This is most probably, yes, a partial tear of both the supraspinatus and the infraspinatus tendon right here, upper portion of the infraspinatus, and the posterior portion, the lateral portion of the supraspinatus. So this is a partial tear. Let me see if I can make a proper measurement. I'm sorry, I did have some sleep this past night, but I'm still quite sleepy. Sorry, I'll be yawning no matter what I do. So this is a tough one to measure because it's angled wrongly. See, it should have been angled right like this, and it's angled twisted, so it's a tough one. I don't know. How do you measure this crap? Yes. Oh, just do it like this and call it 1.5 by 0.6. And the other one is quite similar. Just call it 1.2 by 0.6. This is supra and this is infra. So let's grab a T1. The patient shake it a lot on the axial sequence, so the technician repeated it a bunch of times. This is clearly not a T1. This is probably just a PD without fat saturation, which by itself makes no sense. This is a T1 because I can see liquid right here and it's black. Let's see if this is also a T1. Is this a T1? I guess it is. No liquid is shining, so there is no. And see, let's just compare. Yes, see, bright on PD and bright on this sequence without fat saturation, which should be a T2 or a PD. Excuse me, a PD without fat saturation. So this is useless. Still, I can see here we have some narrowing of the cartilage and the joint space, and it seems maybe a tiny osteophyte right there, and kinda right there. So I can see there is mild arthrosis on the glenohumeral joint. Also there are spurs all over the tubercles of the humerus, and also there is edema, bone edema on such tuberosities. So arthrosis is right here, and it's really hard to speak of the glenoid labrum because this is not a properly done exam, unfortunately. Hello, Hodem. What's up? I don't think it's a complete rupture because I can actually see its ending right here. So there is still a tiny portion of the supraspinatus right here, but it could be a complete rupture in function because there is most of the tendon is gone, but you know, see, I have a tiny portion still here. and it goes into the rupture. And if you check the status of the muscle bodies, they are hypertrophic, both the supraspinatus and the infraspinatus, and partially fat substituted, fat infiltrated. So it is a chronic disease for sure. So this is probably a chronic tendinitis that got worse with a recent tear. I have a template for this, of course. Why not? And I just I forgot about the long head of the biceps tendon. Of course, we are supposed to see if there is any tear of that. I'd rather check for the axial view first. So it's right here. There is fluid distending its sheath, and it's here. It's not ruptured, but it's clearly thickened, and it has some degree of supraspinatus, tiny portion, and the long head of the biceps tendon right here, there, partially with clear signs of tendinitis, tenosynovitis. So let's go for a report now. There is a moderate joint effusion with synovitis. And we have a distension extended subcoracoid joint recess. Also, we have a distended subacromial subdeltoid bursa. We have a partial tear of the supraspinatus and the infraspinatus tendons. The same I can say about the infraspinatus. And subscapularis, how is the subscapularis? It's quite bad too. There is tendinosis, and I can't say much about tears. There is some bone edema and subcortical cysts. Can't really say it's ruptured. So let's just make it a tendinitis. And the teres minor is here. Teres minor usually isn't is usually normal, so and we have the muscles are hypertrophic and partially fat infiltrated. And we are done. Just going to summarize this report so we can move on. The moderate osteoarthrosis and synovitis of the acromioclavicular joint. Similar disease on the glenohumeral joint. The tendinosis. Let's see if we can get a shoulder, properly done shoulder scan so we can actually tell stuff. Usual, more than the usual stuff, the gross stuff about such complex joint. This is good enough. This is a terrible, advanced, all over the place disease, so this is good enough. Oh, this patient has his right shoulder too. He does. So let's open up the right shoulder and download the images. It's usually quite the same from one side to another, so I'm just going to copy and paste. Stuff from the other side so we can properly. So this is the left shoulder, and she also has a right shoulder scan, which is this one. Yes, and it seems quite similar indeed. Let's see. So I was looking. Yes, I was looking at this. And now I'm looking at this, right? Yes. Yes, this is it. This is the right one. So the rupture, the tear is less prominent. Is there any tear? Doesn't seem so. So this is even worse scan than the other side. I can't really tell. They did manage to make a worse scan this time than the other. So the left side is even worse. There is a tiny rupture right here. 0.0 by 0.5. Let's see if I can. Yes, it's there. Probably. It might be there. So shaky I can't really tell for sure. And this infraspinatus tendon right here, it's odd to say the least, but it's just, man, this is so bad. So bad. Can't really do it, can they? So yeah, there is probably a rupture right there, and I can't really say there is a ruptured infraspinatus, unfortunately. Or can I? No, I don't know. It's crooked. It's too crooked for me to say anything, really. It's just, is it? I don't know. I guess this is a type that is minor, probably. There is minor right there. And this is the infraspinatus. It ends right here. And it's just wrong. See? It's angled all wrong, and it just misses the end of the supraspinatus tendon right there. It's so difficult to see on these thick slices, because they make 4mm slices in those old scanners. So I think there is something missing right here. Probably there is a tendon missing here. It gotta be the supraspinatus, the infraspinatus, and this is surely the teres minor right there. I can see it's missing here, and it's too freaking crooked. But this is the infraspinatus, this is the teres minor, and the infraspinatus just finishes around here somewhere. It seems to be indeed ruptured. So let me see if I can put my marker there and make an educated guess. It might be just around here. Let's see. I think this is the teres minor right there. Let me grab a pointer, a crosshair. Crap. This doesn't help much, does it? Yes. This is it. See how twisted it is? It's just too freaking crooked. Yes. So this is probably teres minor, and this is probably the site of rupture of the infraspinatus. So I'm going to measure it as close as I can. It's a 3.9 distance approximately, and this should be good enough. There is a moderate effusion, there is bursitis, there is the same subacromial bursitis. This is such an awful exam, come on. There is mild arthrosis and synovitis of the acromioclavicular joint. There is also hypertrophy or atrophy and fat substitution, fat infiltration of those muscles, and the same degenerative signs. See? Osteophytes, narrowing osteophytes. This is also arthrosis all over the place. So let's just see this through. It's yes. Mild partial tear of the supraspinatus, complete tear of the infraspinatus. Let's see the long head biceps tendon. Where is it? Is it here? Is it rupture? It's missing. It's not there. See? Right there. It's missing. The long head biceps tendon is missing. Is it missing on the top? It is. Is it dislocated maybe majorly? No, it isn't. I can see it here in the sulcus. Let's see the T1. It's also missing here. There is just a tiny thingy on its place. So this subscapularis tendon is looking odd, to say the least. It seems to be partially ruptured too. Yes, it is right there. Its tip is ruptured. It goes well until this place and then it goes bad. Now let's see if I can see it here. No, of course not, because this scan sucks. Whatever. Let's see. Yeah, it's a goner. I've just measured this and this and maybe this. Oh. And complete rupture of the biceps. So and partial of the subscapularis. Bursitis, hypertrophy. I suppose there is some trophic changes of the subscapularis, but not as much as the other tendons of the rotator cuff. So we are done here. I'm just going to read it, make sure I didn't miss anything, just to be sure. No, it's all right. Just making a couple of phrases a bit shorter to make it easier to read, because if you report anything really and nobody reads it, it's the same as you've never reported it. So make sure reports are readable. Always. So we have a right knee, MRI scan of a right knee. Now it's a 27-year-old male patient, and it says he has gone through a car crash. So car crash knee. Let's grab a template, a normal template. I suppose this knee isn't normal. It's probably fractured. So this is a better scanner for sure. For sure, this is a better scanner. This is a coronal PG with fat saturation, and this is a fat saturated sagittal PD. So the resolution is still very low. The meniscus aren't really properly imaged, but we can say a bunch about this image. This is probably a newer kind of a low field scanner because resolution isn't good, but saturation is. So sounds like a well calibrated crappy scanner. So meniscus fine. Let's just roll over the bones to see if there is any contusions, any signs of trauma. No signs of trauma. The technician seems to hate us and fibulas because he didn't image the entire fibula. He just missed it because no, it's just a bone. Why? Just because it makes a great part of the knee joint? Come on, no need to image the entire knee joint in a knee joint exam. Just the parts the technician feels like imaging. So the meniscus and the cartilage seem fine. No signs of collateral ligament ruptures. The tendons also, those that are properly imaged, seem okay. Quadriceps and patellar tendons. Patella is properly placed. Anterior cruciate is here. Posterior cruciate is there. Also looking for meniscus tears on the sagittal view, which is terrible because this isn't a good scanner, just a new one, I suppose. So this is a 2-1. It's shaky, but it's okay because this is a normal exam. So this is the axial view. As much noise as there probably can be. The anterior cruciate is fine, the posterior cruciate also, the collaterals are okie dokie, and the parts of the tendons that the technician decided to scan are also fine. It seems he hates the quadriceps femoris also. The semimembranous is okay, and the popliteal tendon right there and muscle seems fine. I can't really tell. He did a unsaturated oblique for the anterior cruciate, which means nothing to us, and he also did a useless oblique sagittal acquisition filled up with noise and kinda shaky, which doesn't help us a bit, but it is here, so it's best than not having it, I suppose. The muscles are eutrophic, which is fine, and we have no significant joint effusion. This much liquid is fine. This is a normal joint for sure, so we are in luck. This is just a normal joint, a normal knee, no signs of trauma, nothing is ruptured nor inflamed nor edematous. Let's grab a lumbar spine, shall we? Lumbar spine is here. This is a 41-year-old male, and he says, let's see what he said here as I open his images. Did I open it? Did it work? No. Didn't seem to work. It says he has lumbar pain. He has lower back pain. I'm going to download once again his images and try to open. Now it worked. There is some error message here, but it's okay. Let's see. We have a regular T2, partially done because it stops early right there. Once again, this is not my fault. I didn't image the patient. I didn't do the exam. I'm just reporting it, and it's clearly done wrong. It should have been a bit more to the left and a tiny bit more to the right, but it's not my call. And I can see here that the entire exam was done with the same marking, so it was entirely done wrong. There is a tiny spot of bone edema right there. Let's grab a T1. A tiny bone edema. Probably a ligament inflammation, a anterior longitudinal ligament inflammation. This is clearly a transitional vertebra. I want to see if this is in L5 or in S1 vertebra. This is probably the last rib. So this is D12. L1, L2, L3, L4, L5. So this is a transitional S1 vertebra. It's an S1 vertebra turning into a lumbar vertebra. So let's call it that. There are some odd looking, awkward, hypoplastic joints between S1 and S2. And there is a rudimentary disc right there between both S1 and S2, which makes this a transitional vertebra. So the segment right above it, it's unstable and should be the first one to go bad. And indeed, as you guys can see, the worst disc of all is this one, and this is the only one with a slight protruded disc. Nothing much, but indeed there is a protrusion. And there is also a rupture of the annular ring, the annulus fibrosum. So this is painful. This could be painful. And there is arthrosis. Let's see if there is any kind of synovitis. Can't really tell. No edema, no joint effusion, just plain old arthrosis. I'm going to put the axial view right here. There is hypertrophy of the perivertebral muscles and also some fat substitution, fat infiltration, which says this patient is not exercising and has been suffering for a long time. This could be also caused by chronic denervation. There are signs of thickening of the yellow ligaments, and there is mild arthrosis of the facet joint. So we have it all. We have our entire report right here. I'm just going to grab a template because I have a template for mostly anything. I'm just going to say tiny osteophytes. Excuse me. Where is that? Yeah, right there. Right there. This is L4, L5. So tiny edema spot right there. And we have a single protruded disc that has a rupture of the annulus fibrosum. And of course we have a transitional vertebra. So just to be sure, the transitional vertebra is S1 and L5S1 has a protruded disc. So let's see right here. We have a protruded disc right there. This is a broad-based protrusion. It goes from a neural foramen to the other. So it's a broad base. It's central, paracentral, and foraminal also. So this is what I described. Are there signs of stenosis? No signs of stenosis. Not yet. But there is thickening of the yellow ligaments and facet joint arthrosis. Also, hypertrophy of perivertebral muscles. Right there. Annulus fibrosum. How is it called in English? Annulus fibrosum or fibrosum. It's the fibrous ring. Yes, it's the fibrous ring. It's also called fibrous ring around the disc. So it's annulus fibrosum. And it's written as ANULS fibrosums. Really? I thought it had a double L. It seems it has a double N. It's ANNULUS. Yeah, it's Latin. So it's Latin. So Latin, it's quite easier to say than it is to write down. So it is what it is. Let's move on. Just finishing up the summary and fixing some typos. It's S1. Yeah. So we're done here. It's off. Finished. Let's grab another lumbar spine because reasons. And just checking here my messages. It's all okay. Downloading. This is a good time for you guys to hit that like button. And if you enjoyed this kind of content, don't forget to subscribe to the channel and share this with people that also likes this kind of content. I really appreciate it. It helps a lot. Oh, this is much worse than the last one. And it's complete, thank God. I thought for a second that it was an incomplete scan. Oh, it's okay. So this is a tissue fat saturated. Oh, I'm sorry. Fat saturated scan. There is edema right there. Right there. It's a small node. It's a intravertebral herniation right there. This tiny spot right here, and it's acute. And there is the same on L5. This is L4, L5, and this is S1. Edema it's a fat, there is fat infiltration also. So this is both fat infiltration and edema. This is modic 1 and 2, which is the most common type. There is a mild stenosis of the L5S1 neural foramen. There are 2 extruded discs on L4, L5 and L5S1. Right there. Extrusion and extrusion with a annular fibrous ring rupture, a concentric type of rupture. See? The concentric rupture right there. Concentric rupture. And on this side there is no vertebral canal stenosis, and I could say there is a mild stenosis right here. Also might be a case of synovitis. Yes. Arthrosis. There is a fracture with a pseudarthrosis of the isthmus of this joint right here. This is L5S1. Both sides are fractured with signs of pseudarthrosis. This is a spondylolysis, bilateral spondylolysis case. I can say there is moderate arthrosis with bilateral spondylolysis, no signs of listhesis, so the bodies are well placed. No signs of, yes, it's going to be eventually a case of spondylolisthesis, but not today, not in this exam. So let's report it. I have a template for this. Of course, most of the times I do have a template. I've been doing this for quite some time, and there is mild fat infiltration and hypertrophy of the muscles. I'm going to be sure to write that down. There is also enough thickening of the yellow ligaments to be of importance right there. So let's just write down the rupture of the fibrous ring, the annulus fibrosum or fibrosum. Right there. 2 extremely common disc extrusions. So we have L4, L5 and L5, S1, and they do make a lot of difference because they are very painful. And we have a fracture with pseudarthrosis of the isthmus of the facet joints of L5S1 on the L5 side. Which is also quite common. This is called spondylolysis. Spondylolysis. Am I missing anything over here? Oh, the small node. There is a small node right here on L4, on the inferior plateau of L4. Yes, there it is. It's done. Let's speak of the stenosis. It's mild of the vertebral canal of L4, L5. And it's mild of the intervertebral foramina of L5, S1. just summarize this so we can go on our way and move on to the next one. Extrusions, osteoarthrosis, spondylolysis, thickening of the ligaments, mild hypertrophy of the perivertebral muscles, and the stenosis, and also the small node. And just checking if I missed anything here. No, it's done. It's as good as it's going to get. So it's finished. Let's move to the next one. Let's see if we have a brain CT MRI here so we can change a bit. Now it's slowing down. Come on. So the platform is slowing down. We are 52 minutes in, and it seems it's all fine and dandy. All fine and dandy. Let's see if the stream quality, how is the quality of the stream? It says healthy and it feels healthy. So let's go. Let's keep on reporting. Let's see what we have here. We have a brain MRI. Yes, we have a brain MRI. Let's see if it loads. Come on. It's loading. Thank you, Holden. Let's open up. Oh, it's so sluggish today. This is not my fault. This is the website's fault. I'm sorry, guys. Once again, let's just clear the cache and rerun everything so we can actually see what's up for us to do. It's just as sluggish as it gets. Come on, go, 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 go. This is tough. Oh, it takes longer to load the exam listings than for me to report a proper scan. So it's really just, it's just stupid sometimes, you know? So it's here. This patient has both a brain scan and a lumbar spine scan. So let's download both. It's a female patient. She is 77 years of age. And for the brain scan, they did it enhanced. And it says she has headaches and memory loss. So, headaches and memory loss. I can deal with that. I can do it. T1, sagittal T1. Right there, no fat saturation. This is fine. Yep. She definitely doesn't look like 77. This is quite a normal brain sagittal T1. Let me grab the T2. So this is a axial T2 because brain fluid is bright and fat is also bright. T2 seems fine. Oh, there is some atrophy. Some atrophy of the temporal lobes. Mesial temporal isn't very good. Still, slight dilatation of the ventricles right there, but there is prominent, yeah, temporal lobes aren't really good. She has lost a lens. She still has one lens to go, and she has gone through some kind of surgery right there on her right eye. So cerebellum and brainstem are fine. Thalamus also. T2 is fine. Let's grab a flare. This is a T2 sequence with an additional pulse to saturate normal brain fluid, and this is really noisy. This is bad. There is some gliotic site right there. Let's compare it to the T2. Yes, gliosis for some reason. Let's just not hope. Yes, it's there. The atrophy is most prominent on the polar regions of the temporal lobes and the mesial temporal regions. So it makes sense with the complaints of memory loss. The amygdala is also affected. So this is probably a Alzheimer's disease case. A classic Alzheimer's disease case. So that site of gliosis has no signs of restricted diffusion. Hey Tim, what's up? Oh boy. Hey, there is something here. Check this out. It seems to be more than just flow artifacts. Really? I did get a nice night of sleep this past night, but it seems to be not to be enough for my grumpiness to go away. I'm glad you are better of yours, because grumpiness makes the day much harder to pass by. There is something wrong right there. I don't know what that is. T1, yes, it's there. There could be a meningioma. It's clearly an extra axial lesion. This could be a Magnum foramen meningioma, which is kind of rare, but could be the reason for this medulla oblongata compression right there. This is also called, in Portuguese, this is bulbo cerebral, but in English it's I don't remember. Let me just Google it. I always miss this one. It's crap. Let me Google it, because I'm at DuckDuckGo, and DuckDuckGo isn't that smart. It says brain bulb, but it isn't. It's medulla oblongata. I don't know how to call it in proper English, just in the Latin. Say it seems to be it's probably medulla oblongata. Yeah, sleeping well is the key, man. And coffee, of course. My coffee is gone. I have to make some more coffee, but coffee and a good night's sleep should be enough for me to get back to my feet. But yesterday I was crushed at BJJ practice. Crushed, man. Really crushed. And today I said to my coach that I was going to do a double practice, a 5 to 7 practice. We are going to do both no gi and gi, and it's going to be awful. I'm going to get crushed both on no gi practice and then on gi practice. This is going to be freaking awful and fun. And I'm quite sure that's where my grumpiness is coming from being sore all over the place. So getting back to the scan, I'm pretty sure this is a meningioma of the foramen magnum right there. Let me just write that down. 1.6 by 1.1. It's right there. It's pretty close to the cortex on most sequences, which is a very common feature. See, this kind of gray is really close to this kind of gray, and this kind of gray right here. If this was a better scan, it would be easier to see. And this is the most common extraaxial tumor on human brains, and also really common right there on, see, it's the same even on diffusion weighted and ADC maps, and it has some expensive effect, some mass effect. Is it partially calcified? It is partially calcified, see? So this is an SW sequence. It's black whenever there is calcification, mineral deposits, or blood products. So, man, this is one freaking shaky exam filled up with noise. Let's see if the coronal plane shows this. See? It's right there on the bone, right at the top of the foramen magnum. Let's see if it enhances. It does enhance. It's brighter than cortical matter, so it's confirmed a meningioma of the left side of the foramen magnum. So let's get back to the start and just summarize what we saw. There is mild reduction in brain volume. There is a particularly big site of gliosis right there on the frontal parietal region. This is mostly middle frontal gyrus or gyrus and prefrontal gyrus right there. Oh, there is some tiny spots of chronic microvascular disease right there. This is the fasciculus one. There is mild dilatation of the lateral and the third ventricles. Also, we have our meningioma right there that we so thoroughly described and localized. I'm just going to measure it from top to bottom. It's 1.5, so it's enough. We have it. We are going to report it just like that. Also, this patient has a lumbar spine scan, which is kind of ugly, but we are going to finish up the brain scan first, because first things come first. And we are going to we are probably going to miss anything if we just jump to the lumbar spine before reporting this. So fascicles 1 is right here. I have a template for this, of course, and the template is really enough. So there is a clear reduction in size of the hippocampus and a atrophic changes of the temporal lobes right there. See, this isn't normal. You're going to report that, and the hippocampus is also maybe in MTA3 classification, could be, and the temporal lobes aren't really good. They seem very atrophic. It could be symptomatic indeed, because it has some mass effect. I agree. And if it bleeds, it's going to be hell for sure. Imagine a swollen meningioma that already takes half of the foramen magnum. This is going to be a massive acute bleeding for sure. Luckily, these kinds of small meningiomas usually don't bleed, they just grow and grow and grow slowly, and this patient is already 77 years old, so she probably will not see an event like that. So we are going to describe it nonetheless. This site. And we also need to describe the meningioma. What else? Also, of course, subcortical matter. No. Just making sure to write down that the most affected sites of brain atrophy are the temporal lobes. Hippocampus are there. No signs of acute bleeding. Let's describe the mass. So it's described just like we said earlier. And let's just summarize this. This should be a quite difficult tumor to access. To do surgery, I suppose it's nearly impossible to remove. MTA3, fascicles 1, mild dilatation, mild hydrocephalus, and that gliosis site right there on the left frontal lobe. No signs of acute excessive diffusion restriction. We are done here. So let's finish this up and move on to our lumbar spine, because lumbar spines are much easier than brains with tumors. Brains with tumors are hard to report, but we survived. So this is a very symptomatic spine for sure. See, chronic, although symptomatic. T1, T2 with fat saturation. So there is a node fracture L1, L2, L3, L4, and L5. There is no signs of a transitional vertebra. So this is 1 and this is 2. Both are fractured. Both have signs of old fractures. This is a partial collapse and this is a complete collapse of those vertebrae. Yes, this seems to be a severe stenosis right there, and at least a moderate stenosis of the canal. We also have extruded discs right there, right there, right there, and right there. Could be a extruded disc right here, but this is clearly subligamentar. There is severe arthrosis right there, severe arthrosis. There is clear pseudo arthrosis of the spinal process. This is called Baastrup disease. I suppose I'm pronouncing it right. It's Baastrup disease. I just wrote that in chat. See, edema, deformities, and pseudoarthrosis between the spinal ligaments. It's a interspinal pseudoarthrosis. So let's report this before it's too late. Also, there is clear signs of muscle atrophy and fat substitution. This is of course caused by chronic denervation of such muscles. So let's grab a template. I have a template for this, of course. I'm just going to add in the fractures. So, let's see if I have, yeah, that is modic 2 and 3 for sure. Are there edematous changes anywhere? No. The STIR steer sequence seems fine. So there is sclerosis and fat substitution of the bone marrow, which is modic 2 and 3. Right there. Let's call the extrusions from here to there. So it's T12 L1, L1 L2. How much? How many? 1, 2, 3, 4, 4. So it goes all the way up to L304. These are extrusions. They go all the way to the neural foramens. Yes, they do. Yes, they do. They do indeed. Let's see how bad is. Yep, vertebral canal stenosis right there. That is mild stenosis. And severe stenosis of the right foramina. And the left foramina is always also destroyed. This is extremely painful. So let's write that down. This is what? This is 3, 4, 5. No, this is 2, 3, 4, and 5. Yes, 3, 2, 4, and 5. L2, L3, and the rest is fine. Atrophy of perivertebral muscles all the way. So what's next? Oh, he's sleepy still. Just summarizing the report so we can move on. Four extrusions. Right there, summarized. Is severe arthrosis. Thickening of yellow ligaments, of course. Pseudoarthrosis of the spinal processes. From, let's see, this one is L1, 1, 2, 3, 4, 5, and this one is S1. Oops. The entire lumbar spine is pseudoarthrotic. So this is Baastrup disease or Baastrup, something like that. I can't really pronounce it. Maybe Google can. And it's done. We are good to go. Was there contrast enhancement in this case? No contrast enhancement, fine. And this is most probably caused by severe osteoporosis. These are called lumbar spine. These are classic cases of lumbar spine fractures, pathological fractures due to, it's called bone insufficiency. It gets so frail that it eventually breaks under minor stress. So this is it. We are done here. Let's just go and move on. So how are we doing? We are 1 hour 20 minutes in. So let's grab a final exam. I have here a arterial brain angiogram, a MRI angiogram of the brain. This should be fun. Let's download and see why did they order this exam. It says patient reports pain inside, pain in her head. So due to headaches, migraines, we are here for a arterial MRI angiogram of the brain. Let's see if we can find any signs of an aneurysm. We could do that. I guess we could. It's here already. That's important close right there. A time of flight unenhanced noisy sequence. Let's hit an NPR. So we have an NPR. Let's do ourselves a favor. It's all shaky and it has double bilateral double artifacts, which means the technician can't do a proper setup on the sequence, so he did it wrongly and distorted the entire image. Of course, let's report it anyway because reasons. Why not? It's just every day like that. It's that stupid. He didn't repeat it because clearly he can't do it. So why repeat it wrong once again if you can't set up the sequence properly? You just do it wrong once and send it for someone to report it. So this is the vertebral, the V4 segments over the vertebral arteries. It's clear a left dominant setting and it goes all the way to the basilar artery right there, goes up and bifurcates. This is the superior cerebral arteries and this is the posterior, left posterior P1 segment of the cerebral artery, posterior cerebral, and there is a hypoplastic P1 on the right that is supplied by a enlarged posterior communicating artery right there, which then takes the name of P2 segment of the posterior artery right there. This is P3 and this is P4. So this is a very common anatomical variation. This is mostly artifacts. I can't really say, it's on both sides. This is acquisition artifacts right there too. This is a very bad exam. I can't really say much. This is shaky, so there could be a stenosis here, but I can't tell because it's, see, there is a band of artifacts going right here and yet another band of artifacts going from there to there. See these artifacts? So they attenuate signal right on the spot that is most commonly affected by atherosclerotic plaques and stenosis. So this is a useless exam to do that. This is also one of the most common sites of aneurysm, and it's completely useless to report. This is the right carotid, internal carotid arteries, the petrous segment, the lacerous segment, petrous segment, lacerum segment, cavernous segment. So this is clinoid, ophthalmic, and communicating. Ophthalmic right there, ophthalmic here, and communicating right here. Do you guys know your carotid artery anatomy? You should. This is the bifurcation, anterior and middle cerebral arteries. See how the bifurcation, which is a very common site of aneurysms, is all screwed up. It's impossible to analyze because of motion artifacts and acquisition artifacts. So this is a very poorly calibrated scanner trying to scan a highly difficult, a very complex scan, which is a time of flight sequence. so it fails miserably. I can't really say much about this. Just going to look for anything here. This is a spot, common spot, the bifurcation of the M1 segment of the middle cerebral artery is a common spot for vascular aneurysms. Also, the slices aren't isotropic, so the MPR is all blurry and crappy and blocky, so it's stupid. I can't really say much about microaneurysms here. So this is a complete useless scan. This is just to make a fool of the patient. I'm just going to be clear on the report that the artifacts are very bad for any kind of proper report. Can't really do much. Posterior communicating artery on the left is hypoplastic. I'm sorry. And the P1 segment on the right is hypoplastic right there. This is quite common. And I almost can't see the anterior communicating artery, but it is there. Just going to take a sagittal view to see if there is any pericallosum close by. And see how blurry this is? See how bad in a scan this scan is? This is just any small 0.3, 0.2 aneurysms that could be seen in these sites is just impossible to see. See how these artifacts narrows the vessels, which makes no sense. See? This is just artifacts. These are the worst kinds of artifacts. If the only angiogram you can do with your MRI scanner is such a horrible scan just like this, it's best not to scan, because you're just giving up on making a proper diagnosis. It's impossible to make a proper diagnosis with this kind of scans. This isn't a scan, this is a scam. This is a proper scam on the patients. I'm just going to be on my way. Communicating. Yes, this is it. And we are done, thank God. This is just stupid. Yeah. It is. I have a bunch of reports to do, a bunch of reads to do on low field MRIs of joints and bones. So joints and bones, we can probably get something out of the exams, but this same place insists on making brain scans and angiograms on a 0.3 Tesla old machine. It's just stupid. It's just impossible. This scan is fabulous, close to what I have seen from this other place. It's just freaking stupid. It makes no sense. It's just impossible to read. It's just make believe. Really, I can't really get that. So I'm going to grab some coffee. We are already 1 hour and a half in. Thank you so much, guys, for being around and for liking and subscribing and sharing. Thank you so much. We'll see each other again, maybe in a couple of days, maybe tomorrow. I don't know. It depends on how grumpy I'll feel, but I'm surely planning on streaming 3 times a week. Today is Wednesday, so I'll see you guys Friday. I guess Friday will be fine. Yeah, Tim. 0.3 Tesla. Come on, man. It's just stupid. Just makes no sense. So, but those guys have to make money. They make money out of anything. It's crap, and it takes so long to make a sequence. It takes so long to make a sagittal T1 of a knee, and it looks shitty. So it makes no sense. And it usually those scanners are almost as expensive as a regular scanner, and they are impossible to make proper maintenance and to upgrade. There is no way you can upgrade such an old machine. I have seen some cases that I felt like asking the owner of the clinic why he kept insisting on such old machines, but I guess those guys are married to the machines. They just won't divorce the machines, you know. They paid good money for them and they want to make money from them as much as they can. Most like they are waiting for the police to arrest them for scamming the patients, because it's a scam. It's a freaking scam. It makes no freaking sense whatsoever. But it's time to go. See you guys until next time. I'll see you guys around. Thank you so much for being around, and we see each other. I'll be streaming most probably next Friday. So see you.